Madam Chairman, thank you very much, and I'd like to thank the organisers for inviting me here to speak to you today and to give you my views on islet cell transplantation. What I'll do is I'll give you a bit of background, how it fits into beta cell replacement therapy, a little bit about islet cell transplantation, some of the difficulties, some of the successes, and the most recent data that we have. This will be a sort of global talk, but I will show you data from Europe and specifically also from the UK. This slide just shows on the right-hand side our transplant ward, which is next to our diabetes centre on the left-hand side. And I think the close adjacency of these two units is crucial in the management of patients with type 1 diabetes who undergo islet cell transplantation. So first of all, my slide is just showing my duality of interests, although I'd like to think that none of my previous work with pharmaceutical industry will impact on this talk or indeed islet cell transplantation. So just to start off with a little bit of history, many of you may have seen this picture before and many of you may not. And this is the picture of a single bed, and the clock has stopped at 10 to 2. And this is the bed of Frederick Banting. And the timing is important because this was the time in the early hours of the morning when he couldn't sleep, and it came to him that it might be possible by ligating the pancreatic duct to actually get hold of insulin, to be able to isolate insulin and use it for human use in the management of type 1 diabetes. And if you read the newspapers at that time, you would see that there were claims that we had a cure for type 1 diabetes. Type 1 diabetes was now cured. I think they probably knew at that time that type 1 diabetes wasn't cured, and we certainly know that today. And that by simply replacing a missing hormone, you do not cure type 1 diabetes, nor can you treat it completely successfully. And indeed, if you go to Banting's house in London, Ontario, in Canada, you will see the flame of hope burning outside. And this flame of hope will continue to burn until we do have a cure for diabetes. And as you can see, I took this photograph a few months ago, it is still burning. And even with transplantation, we do not have a cure for diabetes. So, as I said, what I'd like to do is to place this into context, place islet cell transplantation into context in terms of beta cell replacement therapy, and just say something very briefly about whole organ pancreas transplantation, which I think it's fair to say is much more common, and certainly much more common in the UK, and we do many more whole organ pancreas transplants than we do islet transplants. And the first whole organ pancreas transplant was actually performed in 1966 alongside a kidney, and then in 1967 on its own. And as you can see, the pancreas here is plumbed into the systemic circulation, and indeed we continue to do that today. If you look at some of the early data from 1970, you will see that this was not a particularly successful procedure. You can see these first number of cases, and you can see the mortality rate was extremely high for what is a major operative procedure, with many patients dying from sepsis or the acute operative procedure itself or complications associated with that. So that was in 1970. But if we move forward, and I show you some of our own data here, we perform approximately 2 whole organ pancreas transplants a week, so we do somewhere between 80 and 90 a year. You can see on the top line the simultaneous pancreas kidney transplant data showing 1-year patient survival of nearly 93% and 1-year graft survival of around 90%. And we've been doing these for 8 or 9 years now, and you can see our cumulative patient survival is just under 90% for simultaneous pancreas kidney transplants. And it's still pretty high for pancreas transplants alone and pancreas after kidney. So we've certainly improved in recent years. And these data from Oxford are reflected globally If you look here, these data are a little old now, but 2007, you can see survival data going out to 3, 5, and 10 years. And certainly for the simultaneous pancreas kidney transplant, you can see functional grafts at over 55%. And this degree of success is comparable to other whole organ transplant procedures, whether it's heart, kidney, or lung. So we have a very successful outcome, and you can see in terms of long-term survival and long-term benefit, the simultaneous pancreas kidney is superior to pancreas transplant alone and pancreas after kidney. And indeed, if you are a type 1 diabetic patient with renal failure, end-stage renal failure, and you are being considered for a kidney transplant, the long-term data suggests that a combined pancreas and kidney, you will do a lot better with that combined approach, the simultaneous transplant, than you will with just a kidney on its own. So that's really to set the scene. That shows you what we can achieve with whole organ pancreas transplantation. But the Islet approach is quite different. As you can see in the top left-hand corner, whole organ pancreas transplantation, as I've mentioned, is a major operative procedure. And we have to assess our patients very carefully. We still assess our patients carefully for islet cell transplantation, but as you can see, and I'll explain this in more detail in a few minutes, there's a little cannula here that goes under the skin into the liver. And in terms of the procedure itself, this is a lot simpler than performing a big abdominal operation. So just to put this all into context, how do these transplants all fit together? In terms of whole organ pancreas transplantation, as I've mentioned, we perform simultaneous pancreas kidney, and these are probably the most commonly performed operation for most people with type 1 diabetes having beta cell replacement therapy. But we also perform pancreas transplant alone and pancreas after kidney. In terms of islet cell transplantation, the most common procedure is islet transplant alone. But we do islets after kidney, and we might do a simultaneous islet with a kidney. And you may say, why would you want to do that? Well, I give you 2 examples that I saw last week in clinic, where we had someone who, for religious reasons, did not want to have a blood transfusion. The surgeons consider pancreas transplant to be a major procedure with a high risk of requiring a blood transfusion, and the patient has opted for a kidney and islet, so the kidney being a less invasive procedure. So we have these different treatment options available. Generally, SPKs are for people with end-stage renal disease, but as you can see, and I'll come back to this, islet cell transplantation is for type 1 diabetes patients without long-term complications. It's more for patients with problems with control and hypoglycemia, which I will come back to. So what's the background to islet cell transplantation? Well, there's quite a bit of data around, and if you look at the data between 1990 and 2000, you will see that there were just under 300 islet transplants performed, and unfortunately, only around 40% showed some graft function. And as you can see further down this slide, just over 12% of these 267 allografts actually achieved insulin independence that lasted longer than a week. And you can see that just over 8% achieved insulin independence for more than 1 year. So prior to 2000, this was not a particularly successful procedure. But everything changed in 2000 following the publication in the New England Journal of Medicine of this paper by James Shapiro from Edmonton, looking at islet cell transplantation in 7 patients with type 1 diabetes using a glucocorticoid-free immunosuppressive regimen. This is the Edmonton protocol, and this transformed islet cell transplantation. As I've mentioned, it was performed in 7 consecutive patients, and these 7 patients were reported to have, or 85% of them, have insulin independence at 12 months. And as you can see, this is completely different to everything that had gone before. And there were 4 key elements to the Edmonton protocol that transformed islet cell transplantation. The first was the retrieval of a large number of islets from the donor organ by the technique used in Edmonton. The second is that the patients were also very carefully selected, and patients with type 1 diabetes with problems with severe hypoglycemia were the patients selected for this procedure. As I've mentioned, it was a steroid-free immunosuppressive regimen and also a xenogenic-free isolation media. So no media from any other organism or animal, whether it be pig or cow. So these were xenogenic-free isolation media. And this transformed the whole procedure. And then in 2006, after 6 years of using the Edmonton protocol, we saw a further publication in the New England Journal of Medicine, and this really presented some longer-term data. And you can see here, I've summarized the conclusion in which it says that islet cell transplantation with the use of the Edmonton protocol can successfully restore long-term endogenous insulin production and glycemic stability in people with type 1 diabetes, but insulin independence is usually not sustainable. But the next sentence is crucially important, and that although patients return to insulin injections, persistent islet function, even without insulin independence, provides both protection from severe hypoglycemia and improved levels of glycosylated hemoglobin. So even though patients return to small amounts of insulin, the management of their diabetes is so much better. This procedure is performed for people with hypoglycemia and loss of hypoglycemic awareness. And even though patients need to go back onto insulin injections, the problems with hypoglycemia, as I will show you, are significantly reduced, and it is easier to achieve target HbA1c levels. And on the back of this paper in 2006 in the UK, the National Institute for Health and Clinical Excellence issued guidelines, national guidelines for transplanting donated pancreatic islet cells for people with type 1 diabetes. And what this means, and this is unique globally, is that islet cell transplantation is available on the National Health Service. And it's currently funded to perform 100 islet cell transplants a year. And I'll add at this point that we currently do somewhere between 30 and 40 transplants a year. So we currently have the potential to do more based on the funding that is available. So this is now available in the UK on the NHS. And just for completeness, we also have guidelines for autologous pancreas islet cell transplantation. So patients, for example, with chronic pancreatitis who may have pancreatectomy for severe abdominal pain, hospitalization, and vomiting. Occasionally, surgeons and the patient feel it is severe enough to require pancreatectomy, and in these patients, we can try and isolate the islets, give the islets back to the patient, and hopefully make the management of their post-operative diabetes better. We will not make them insulin independent. They will still need insulin injections, but it will make their management significantly easier. So what about worldwide islet cell transplant activity since the Edmonton protocol came into being? Well, you can see here there's a lot of activity in Europe. There's quite a bit of activity globally, but particularly in Europe, you can see the colored blobs for yourself, green being the most frequently performed. You can see that in the UK, we do somewhere between 50 and 100 a year. I said it's around 30 or 40 probably. Occasionally, we do get up to 50, but it's about 30 or 40 a year. But you can see in the rest of Europe, depending on your center, anything between 10 and over 100 islets. Sorry, this is not a year. This is in total. Sorry, this is since the program came in. But you can see there are major deficiencies in this map. For example, in America, where this is not available, other than as a research tool, and the numbers here are extremely small. And if we look across Europe, there are a number of European centers performing islet cell transplantation, and many of those are more than just the UK, but the UK in particular does this as a national consortium. And I'll say a little bit more about that in a few minutes, but we do not work as individual centers. We only have 2 isolation centers in England, but those 2 centers provide islets for 6 transplant centers across the country. And we've shown quite clearly, or others have shown quite clearly, that you can move islets around post-isolation so that they can be transplanted in centres far removed from the isolation centre. If you look at how islet cell transplantation is mainly performed, you can see that most, certainly all in the UK, so when this slide was put together a couple of months ago, it was islet transplant alone, but you can see there are some centres doing simultaneous islet and kidney, and others doing islet after kidney. There are also other types of transplantation. It's often quite advantageous to do an islet transplant in patients who've already had some other transplant. So you can see here, islets have been performed after lung transplants, after liver, and after kidney and after heart. And the real advantage of doing this is that your patient is already on an immunosuppressive regimen. And our immunosuppressive regimen for islet cell transplantation is very similar to that for whole organ transplant. So if you've already got somebody on immunosuppression, doing an islet cell transplant does not increase the risk, certainly in terms of immunosuppressive therapy. So just to drill down a little bit further, why do we perform islet cell transplantation? Well, quite simply, it is to improve the quality of life of people with type 1 diabetes who suffer severe, recurrent, and potentially life-threatening hypoglycemia. And that's the really important criterion, life-threatening severe hypoglycemia. It is also capable of improving hypoglycemic unawareness. The mechanisms behind this are unknown, but it is pretty impressive, in fact amazing, that within a week or two of having an islet cell transplant, many patients will start to develop some symptoms of hypoglycemic awareness that they haven't had for many years. And I've put a question mark here to achieve insulin independence. Certainly in the UK, this is not an objective. And if a patient comes to our clinic requesting an islet cell transplant because they want to come off insulin injections, we probably wouldn't transplant them because that is not a realistic expectation of this procedure. There are, however, I think it differs slightly across Europe and certainly in Canada over this, and more than one transplant, which we also perform in the same patient, is more likely to achieve insulin independence. And as you will see, insulin-independent rates are reported. So how do we go about preparing the islets, and then how do we give them? I'll just very briefly, without going into too much detail, I'll very briefly go through this. Clearly, we require a donor pancreas, and when the organ is removed at the time of surgery, along with other organs, the pancreas transplant, through national coordination, certainly in the UK, is referred to one of two isolation centres who are on call, a 1 in 2. So we do isolations every other week. There is a third centre in the UK, in Edinburgh, but the two in the UK alternate on a weekly basis. So we have a dedicated islet isolation facility which was purpose-built, and as I'm sure you can imagine, has to conform to very strict criteria in terms of infection control, isolation, and you can see here the number. We have 3 or 4 rooms for the various processes of islet isolation, which actually is embedded within our diabetes centre. So the pancreas comes to us from either heart-beating or non-heart-beating donors, and generally we stick to a donor age of between 25 and 60, and a cold ischemia time, we don't want this time to be greater than 8 hours. So we need to get the organ within 8 hours into our laboratory, and ideally the donor should have a body mass index of less than 35. We do take them less than 40, but ideally less than 35. It's not difficult to isolate islets from an obese individual with fat, but though around the pancreas and around the islets, but the islets tend to perform less well in the longer term, and that's the reason for restricting ourselves to this body mass index criterion. So the first part of the procedure is sort of dissection. So the pancreas will come to us with a bit of small bowel. It will come to us with spleen and quite a bit of fat, as you can see, and a mental tissue. And this is dissected away so that we have the pancreas, as you can see here, at the bottom of the slide. The pancreatic duct, we then place a cannula into this, and you can see it's tied off, and collagenase is infused. So this is an enzyme to help break down the the pancreas tissue so that ultimately we can separate the exocrine from the endocrine tissue. And you can see again in the bottom left-hand side of the slide, the cannula is in place and we're leaving that for some time to infuse. And then digestion takes place, and you can see this is done in a hooded cabinet so that we digest the pancreas down and end up with something looking like this. So this is an optimal digestion. You can see the volume, and I'll show you even further in a second, the volume becomes quite small. We get down to about 5 mils of endocrine tissue. So the procedure, we then move into a gradient separation, density gradient purification, so the dense exocrine tissue falls to the bottom, whereas the less dense, the lighter endocrine tissue comes to the surface. The islets are then collected into a bag, and they're then cultured. And generally now, we culture islets for around 24 hours. This tends to improve the subsequent function of the islets, but it also gives us extra time. Although the clock is ticking, we have about 24 hours to contact our patients, get them into the hospital, get them onto a sliding scale, onto insulin glucose infusion, so they're nice and stable when they come to the procedure. This is not a rush procedure because we culture the islets for 24 hours. And then the following day, or 24 hours later, we look at the purity and the viability of the islets. And you can see here we aim for a purity of over 50%, a viability of over 70%, and we also estimate the yield. And the yield is important because you require a larger number of islets for larger individuals, and I'll come on to that in a second. Obviously, there's a gram stain performed, an urgent gram stain to make sure there's no infection that's occurred during the procedure, and you can see that really the only typing that we do is that of donor blood group, but we do look for antibodies, particularly donor-specific antibodies after a first transplant. So we look, if the islets are fully functional, we're happy with their purity and viability, they will then be handed over to the clinical team for transplantation. And the transplant surgeon, whatever he tells you, all he does is hold the bag. So he's a glorified drip stand, which is a little bit different to a whole organ transplanter. So the transplant surgeon holds this bag, and you can see it's a very small volume, about 25 mils, and the islets are administered by a percutaneous transhepatic approach into the portal vein, and we only use a local anesthetic. So the patient will come in the same day, they go down to the radiology suite, and this is performed under radiological guidance. Patients get antibiotic and heparin cover. Antibiotics obvious, heparin so that we don't see portal vein thrombosis. The islets are infused over 10 to 15 minutes, monitoring the portal pressure at all times to make sure that they do not develop portal hypertension. If this does happen, we slow the infusion rate down. At the end of the procedure, the tract is then embolized, and the patients return to the ward, where they have at least 12 hours bed rest, usually about 6 hours, on the right-hand side, laying on their liver. I don't know whether that helps, but they lay on that right-hand side where the procedure has been performed. But the crucial thing, and this is where I come in, is the management of the diabetes. These islets will not work straight away. They may take a number of weeks to start to function. But until they're functional, and even when they're fully functional in the early weeks, glucose is toxic to islets. And my most important job is trying to keep blood sugars between 4 and 6 millimoles per litre immediately post-operatively and then for the ensuing weeks. And as you can see, the patients tend to go home within 2 to 3 days. This just shows you finding where to put the islets into the portal vein under X-ray guidance. So as I say, the crucial thing from a diabetes point of view is management of glycemic control, particularly in those first 48 hours and few days. Patients do get a liver ultrasound just to make sure that there's been no complications, and I'll mention something about that in a second. But they go back onto their pre-transplant insulin regimen almost exactly. But then hopefully over the next week, 2 weeks, 3 weeks, they start to see a reduction in their insulin dose as the islets start to take over. I think the important thing to mention here is the intensive outpatient follow-up. We see patients twice a week straight after their transplant, and we may do that for 2 or 3 weeks. We then see them weekly, and then at 3 months, we'll then see them monthly. So this is quite intensive follow-up, both in terms of glycemic control and also immunosuppression. We do, in addition to our clinical program, we have a research program, and one of the things that we do in Patrick Roseman's laboratory is to look at insulin secretion in individual islet preparations, and you can see here, looking at within the individual islets, first phase and second phase insulin secretion. How this relates to long-term outcome, we don't know, but this is part of the research program that we're currently conducting. So the people that we take for islet cell transplantation currently are adults. We do not take children or anybody under the age of 18 because of lifelong immunosuppression. Hopefully this will change over the next few years, but at the moment we take adults only. And as you can see, our patients with type 1 diabetes, they have to have gone through a very active management program. We have to convince ourselves that they have had every possible opportunity in terms of medical management, from multiple daily injections to insulin pump therapy. Islet cell transplantation is one end of the spectrum in the sort of treatment continuum for type 1 diabetes. And we have to make sure that patients have had appropriate education and there's nothing else that we can do when they come for an islet cell transplant. And you can see here the crucial criteria is impaired awareness of hypoglycemia and recurrent severe hypoglycemia, 2 or more episodes in the previous 2 years. And we like them to have normal liver and renal function, and if they've had a kidney, we'd like the kidney to be functioning well post-transplant. There are a few exclusion criteria that I will just mention. The body mass index is important because the bigger you are, the more islets you require, and it's very difficult to get an appropriate islet yield. A good yield from a single pancreas is around 30% of available islets. So you can see that if we have a large person, we will need a very efficient isolation procedure. And in turn, those islets deliver insulin, and we have a cutoff of 0.7 units per kilograms per day pre-transplant insulin dose. And you can see there are some other exclusion criteria here relating to previous infections and neoplasms, again because these patients are on lifelong immunosuppressive therapy. We take referrals only from diabetologists. We used to take referrals from general practitioners, but our clinics were overloaded because unfortunately most general practitioners did not appreciate the referral criteria. We do have quite a detailed assessment workup, not just medical but also psychological. So all of our patients have to see a psychologist because it's a transplant, and it also requires very intensive follow-up, much more so probably than whole organ procedures. And we have to have long discussions over the risks and benefits. The benefits of having the transplant, and clearly the risks largely of immunosuppression, which I'll come back to in a second. The follow-up, as I've mentioned, is intensive. Medical or metabolic control, immunosuppression. So, for example, patients have to have certain drug levels measured quite frequently initially, and even long-term, they have 3 monthly tacrolimus levels. And this is important. They stay on lifelong immunosuppression. Even if their graft fails, they have to stay on immunosuppression because should they ever need another transplant later on in their lives, it will make it almost impossible for them to have a transplant. So patients have to be warned that the islet transplant may fail, but that they will need to stay on these drugs, and they will stay on them for life and have to come to hospital for blood measurement levels. We assess graft function, and we tend to do this with a meal tolerance test, and I'll show you some meal tolerance test data in a second, and clearly patients are seen in our clinic for general medical review. I mentioned in the UK that we have 2 centres in England, so Oxford and London, that isolate islets, Oxford and King's, and we have Edinburgh in Scotland. And these centres, particularly the 2 English centres, supply islets across the UK, and we've published data showing that islets travel very well. And this is probably this is the most efficient way of conducting an islet cell transplant program, to have a nationally coordinated program with the transfer of islets from 1 or 2 centres. This just shows our activity between 2008 and 2012, and you can see that we had performed around 50 in the UK between 2008 and 2012, since this became available on the NHS. A routine islet transplant is somebody who gets one for the first time. A priority is a top-up. So I mentioned that many patients, we rarely isolate more than 30% of the endocrine tissue. Patients do require insulin injections. We find that if they get a top-up, ideally within 3 to 6 months, we don't necessarily make patients insulin independent, although sometimes we do, but the long-term effect of that graft is much more beneficial. We get a longer long-term benefit. So we try to prioritize a second graft. And in the UK, you get 3 grafts on the NHS. 2 of them you can decide upon locally, and the third one is agreed at a national level. And I just show you some data here on hypoglycemia. You can see here the annual hypoglycemia rate of individual patients in blue, and this is pre-transplant. And then you look at the hypoglycemia rates in red post-transplant, and you can see that hypoglycemia has virtually disappeared. And hypoglycemia has virtually disappeared with almost and often normalization of the HbA1c. Just showing you some of our Oxford activity here. This is now 12 months out of date, but you can see the vast majority of ours are first transplants. Unfortunately, although we would like to do a second and sometimes a third transplant, because of graft availability, we don't always get top-ups within the first 3 to 6 months, or indeed within 12 months, and then it becomes a second transplant rather than a top-up, and that's then routine. But if you look at some of our, I just took 1 year here, 2011, 2012, you can see we performed 8 transplants in this year. We restored hypoglycemic awareness in all patients. 6 patients had normalization of their HbA1c, or less than 6.5%, should I say. 6 of them had a reduction in daily insulin requirement, and 2 of them were insulin independent. They came in with a mean HbA1c between at around 8.2%. What are the complications of islet cell transplantation? These are pretty rare. In the last 5 years that I've been involved in the program, we've had 1 cannulation injury of the bile duct, where a patient had to go back for laparoscopy to have around 400 mils of bile removed. And we had 1 post-transplant hematoma, which we just observed. I think the patient did require a blood transfusion, but didn't go back to theatre. And you can see that in the NICE guidance that I mentioned earlier, you can see that these are recognized side effects or adverse outcomes associated with the procedure, including occasionally portal vein thrombosis, and hence the need for heparin, which I mentioned at the beginning. Data are also collected internationally, and these are collected by the Collaborative Islet Transplant Registry. And there are regular annual reports published on this. This is the report from 2011. These are data from across the Europe and America and Canada. They don't include the UK. Currently, the UK does not contribute to this, the Collaborative Islet Transplant Registry. But if you look at the data, you can see here, if we look at 1 year, 3 year, and 5 year insulin independence, you can see 50% are insulin independent at 1 year and 25% at 5 years. But importantly, absence of severe hypoglycemia, and this is why you're doing the procedure, 90% resolution at 1 year, extending out to 50% at 5 years. And graft function, we define as having a C-peptide of greater than 0.3 nanograms per mil, between 50 and 80% at 5 years. So I think you'll agree this can be considered a successful procedure. Those of you that keep up to date with the literature in this field will also know there was a publication in Diabetes Care in 2012 showing us what's happened since the Edmonton protocol was implemented, and how there have been slight modifications made in terms of immunosuppression and how we isolate the islets, and to see whether there's been any improvements in clinical outcomes over the last 10 years. And if you take the 3 years when the Edmonton protocol was first implemented, and then you take the 3 years between 2007 and 2010, you can see there have been improvements. So the procedure and the outcomes are improving all the time, such that we have three-year rates of insulin independence of just under 30% in 1999, 2002, 27%, going up to 44% in more recent years. So there has been an improvement in the last 10 years in terms of the outcomes of islet cell transplantation. And you can see that out of 677 patients who've been transplanted, over 90% free from severe hypoglycemia at 5 years. In December, the UK data were published in the American Journal of Transplantation, and these data are very similar. These are data on 20 patients with graft survival of up to 36 months, and you can see here we're looking at graft survival over 3 years of around 80%. Similarly, if you look at our hypoglycemia rates, again on the left-hand side of this slide, severe hypoglycemic event per patient year at 23 pre-transplant and 0.56 post-transplant. And our mean HbA1c, I think I previously mentioned this, coming down from 8.23% down to 6.83%. So almost no hypoglycemia with much better glycemic control. But it is all about risks versus benefit when it comes to islet cell transplantation, as with any transplant. But in terms of this procedure, we have to weigh on one side the complications of diabetes, but also the complications of immunosuppression. And I can't underestimate, and certainly not to this audience, the importance of both sides of this equation. There are attempts to improve the immunosuppressive regimens and the immune environment into which islets are transplanted. And there's work ongoing at the moment, and we're part of a European program looking at encapsulation of islets in the hope that maybe you can trap these islets within inside a capsule. It will allow insulin out, but it won't allow antibodies and all the horrible parts of the immune system in. And there have been examples of extrahepatic islet cell transplantation across Europe. Not all of these for immunological reasons, but you can see here there has been macro encapsulation and islets placed in different parts of the body. And of course, certain different parts of the body have different immune privileged sites. The two most immune privileged sites are the eyeball and the testis. Islets have been placed into both in animal models, but I'm sure that in humans that would be less attractive. So ultimately, we view in the UK, and certainly NICE emphasizes to us, it's all about quality of life. And I just want to finish by just really describing to you one patient. And this was our first patient. And this was a patient in Birmingham who had been seen to be driving erratically. His vehicle mounted the pavement. It hit a boy and his brother, went through a garden wall, across the garden and into a house, and killed the child. This man went to prison for manslaughter. It was not accepted by the court at the time that hypoglycemia could cause this. It was considered to be bad driving and manslaughter, and as I say, he went to prison, and he appealed. Unfortunately, at appeal, he had a decent diabetologist who was able to get him out of prison. But at that point, he was referred to the islet cell transplant program. And these were some of his pre-transplant glucose profiles, and you can see they're all over the place. And after his first transplant, there was a significant improvement in his glucose profiles with no hypoglycemia. As I mentioned, we perform a meal tolerance test where we do a blood test at 0 and at 90 minutes. This chap was very fortunate. He went from one transplant and had a top-up, so he got a second transplant within 3 months. And you can see before his second transplant, his glucose went up to 15 with a stimulated C-peptide of 0.18. He had a second transplant, and after his second transplant, his meal tolerance test showed that his glucose only went up to 6.4 after a meal test with a stimulated C-peptide of 0.43. So this was performed, the first transplant in 2009. 2 years post-transplant in 2012, he still had a very healthy meal tolerance test and C-peptide response. At present, he has occasional postprandial hyperglycemia. So we're now just starting to see some high blood sugars after meals. He has complete hypoglycemic awareness, and he's currently in negotiations with the DVLA in the United Kingdom about starting to drive again. which I'm sure you could imagine is a very sensitive issue and something that wouldn't have been considered without islet cell transplantation. This just shows some of his home glucose monitoring profiles, and as I mentioned most recently, he's just had a few postprandial excursions. He doesn't want to go back onto insulin. I don't think there's an indication to do this at the moment, but one thing that we have contemplated is maybe trying some incretin-based therapy to see whether that might help. So to conclude, I hope I've put islet cell transplantation into context alongside whole organ pancreas transplantation. And in many countries, and certainly in the UK, islet cell transplantation has moved from a research tool, research opportunity, into a clinical service which is now fully funded. And I think it's fair to say that whichever data you look at, our NICE outcome measures are being achieved. So we are able to prevent recurrent severe hypoglycemia, we restore hypoglycemic awareness, and achieve good glycemic control. Balanced alongside this, though, we must not forget that these patients require lifelong immunosuppression. But I'm hopeful that even though I showed you some fairly restrictive criteria for islet cell transplantation, we might be able to push the boundaries over the next few years as our excellent data start to show. And I would just finally like to acknowledge members of the clinical team in Oxford who I work with, also our surgeons, diabetes on call, the islet isolation team, and also everybody who works in islet cell transplantation at a national level in the United Kingdom. Thank you very much.